Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone, and welcome to our workshop today about laboratory biomarkers of diseases, liver diseases. Our speakers today are from the, mashallah, their CV is very heavy, mashallah. They are well known. Our first speaker is Dr. Hadi Muhammad Kureri from Department of Gastroenterology and Hepatology, Prince Sultan Military Medical City in Mecca al-Mukarramah. In Riyadh. Dr. Hadi graduated from Faculty of Medicine in King Abdulaziz University, Jeddah in 2009. Also, he granted his Saudi Board of Internal Medicine in December 2014. Also, take the Saudi Fellowship Program of Adult Gastroenterology in December 2017, followed by Clinical Hepatology Fellowship in Toronto Center for Liver Diseases in University of Toronto. Then continue his Transplant Hepatology Fellowship in multi-organ transplant program in Toronto General Hospital at University of Toronto. Dr. Hadi has a very rich administrative and academic duties, mashallah, la quwwata illa billah. He appointed as academic coordinator in medicine residency training program for academic year 2012 to 2013. Also work as a chief intern during internal medicine rotation in King Abdulaziz University Hospital in 2010. Work as a co-leader for medical student group during the 4th, 5th, and 2nd year rotation in 2007 to 2009. He awarded the best R1 resident in medicine residency training program for academic year 2010-2011. And also granted a letter of appreciation from the National Guard Health Affairs for distinguished participation in the 11th Congress of the European Federation of Internal Medicine. He worked in many committees and a lot of, mashallah, memberships, a lot of teaching experience and research interest in liver diseases, and mashallah, he published many publications, completed a lot of researches, and he is also an editor, peer reviewer in ACG Case Reports Journal, and also a peer reviewer for Gastroenterology Report, an international open access online journal. A lot of abstracts, mashallah, and la quwwata illa billah, and presentations. Dr. Hadi, please.
Thank you, Dr. Zahar, for this introduction, and thank you for the Saudi Society of Clinical Chemistry, and thank you for having me tonight. Tonight we'll talk about liver fibrosis, and sharing the slide currently. So liver fibrosis stages, symptoms, and treatment. There is no disclosure to go. And our lecture tonight will go through different definition of fibrosis, and we'll touch on pathogenesis, fibrosis stages, and clinical presentation complications of fibrosis. And we'll talk about how to assess fibrosis, and we'll touch on management. So we'll start with liver. Liver is a valuable organ in our body, is very important, removing toxin, metabolize and breakdown of nutrients. Also is helping us in maintaining nutrition, fighting against organism, is producing clotting factors, and also is a site for synthesis of protein, fat, and glycogen. So it's an important organ, and any etiology affecting the liver, it will affect the whole body. So chronic liver disease is common clinical condition, and it is a continuous inflammation, destruction, and regeneration of the liver parenchyma, which lead to liver fibrosis and cirrhosis at the end. So chronic liver disease is something common, is the fifth most common cause of death worldwide, and is account for around 2.5% of the total death every year. Etiology of liver diseases vary between countries. Currently, the most predominant cause is fatty liver, non-alcoholic fatty liver disease, is almost 49%, and followed by viral hepatitis B, and also is common in our country, followed by Hep C, which is in elimination stage currently. Hopefully we'll reach that by 2030. And other etiologies like autoimmune disease, cholestatic liver disease is contributing as a causing factor of liver disease. So let's go about definition of liver fibrosis. So liver fibrosis or hepatic fibrosis is a dynamic scarring process. So when you have inflammation that will stimulate collagen and extracellular matrix that cause scar. Liver fibrosis is specifically a deposition of extracellular matrix in response to chronic inflammation or injury of the liver, whatever is the etiology, viral hepatitis, autoimmune, or cholestatic liver disease. And the most responsible cell for that is hepatic satellite cells. Is the most important hepatic satellite cells, which is important, is the most predominant cells causing this problem. Liver fibrosis, it is, again, in this slide, if you could see it, you have an etiology causing liver fibrosis. Sorry, I think the slides get off. So liver fibrosis, as I said, the most important etiology is a viral hepatitis and fatty liver. And the most important cells responsible for fibrosis and deposition of extracellular matrix is hepatic satellite cell. As you see in this slide, it is an autoimmune process, cholestasis, metabolic disorder causing liver damage or hepatocyte damage that can promote macrophage and hepatic satellite cell activation, which lead to myofibroblast and fibrosis. Again, you can see it in this figure. It's more in details that when you have inflammation of the liver, that can lead to activation of various of cells and also cytokines that promote activation of hepatic satellite cells, which lead to production of extracellular matrix. Then, so what happened exactly? So over years, when you have ongoing chronic injury to the liver that cause inflammation, matrix deposition, parenchymal cell death, that will lead to scar tissue. And with years, 10, 15 years, 20 in some cases, and in some cases 50 years, that will progress from one stage of fibrosis to another. So from early fibrosis to advanced fibrosis. And with that, you will have disruption of the architecture of the liver, loss of function, and you'll have diminished or weak hepatocyte regeneration. So what's the stages of fibrosis? We have 4 stages, starting from 0, which is no fibrosis, is mainly inflammation of the liver parenchyma. And then you have stage 1 and stage 2 is, in another way, is mild fibrous deposition, some changes in the liver parenchyma, but nothing more than that. Stage 3 and 4 is more of dense fibrous tissue involving the liver. There is a term called bridging, that means the fibrous tissue is extending from hepatocyte or a hepatic unit to another one. And the advanced stage, which is stage 4, that means you have thick and dense fibrosis. As you see in this slides, There is stage 0, which is nothing there. And when you look to this, the bluish purple color of changes here in hepatocyte, around the hepatocyte. This is fibrous band stained by trichome stain. This is called stage 1, when you have like minimal things. Stage 2, which is pre-sinusoidal. Stage 3, which is what we call bridging fibrosis. And stage 4, when you have dense fibrosis around normal liver cells, and this is called regenerative nodule. So stage 4, we name it again as a liver cirrhosis. So when you have stage 4, that means this is a cirrhosis. So it is a viral pathway of chronic inflammation or chronic liver disease, and it is a diffuse hepatic fibrosis, replacing most of the peripheral parenchyma with fibrotic bands. So this is dense fibrotic changes, and reddish cells, this is the hepatocyte, and the light or dark blue, it's the fibrous tissue. So as you see here in gross, this is the normal liver on the left side, and the right side is the cirrhotic liver. You can see some nodules and some groove inside. This is the fibrotic band. Here in this picture, again, this is cirrhotic liver. So small nodule, this is normal hepatocyte, you can say it. And there is some fibrotic band as a groove there. So again, this is the third or fourth picture of liver cirrhosis. So as we can see again in this picture, so you go from stage 0, F0, F2, F1, F2, 3, and 4, which is a liver cirrhosis. This is the progression of liver disease, and usually is a silent disease, so you cannot predict anything. Patient usually is healthy, no complaint. So what about the clinical manifestation?
دكتور هادي يبدو انه الشرايح ما بتتحرك معانا. اللي طالع لنا ليفر هيب فايبروزز هيباتيك فايبروزز من الصفحه رقم 8.
اوكي سوري.
لو بس تاكد لنا انه الشباب عشان يتاكدوا بس.
Okay. So liver manifestation. Can you see the clinical manifestation?
Yes.
Slides? Okay. So clinical manifestation of liver disease or fibrosis, we can look to it in different stages. So from stage 0 to stage 3, which is early to advanced fibrosis, usually patient asymptomatic, no real symptoms, and patient usually asymptomatic. When you go to stage 4, we can divide it to two categories: compensated cirrhosis and decompensated. In compensated part, usually the liver is function is preserved, but with some element of weakness. Patient will feel fatigue, lack of appetite, some weight loss, and other non-specific symptoms. This is usually because the liver is barely coping with body demand. Once the demand is more higher than the liver capacity, patient will go to decompensation stage, which is usually the patient will present with ascites, jaundice, confusion, or bleeding in terms of like GI bleeding or like ecchymosis or petechiae. And this has happened like in a rate of 11% every year. So patient can move from compensation to decompensation in this pattern from like around 11%. And this is related to the underlying liver disease. If there's any other factor, an infection, can push patient from compensation to decompensation. This is like another graph showing the common manifestation of liver disease. You can see this is like jaundice, patient will have ascites, hepatomegaly, something called pulmonary edema, and also muscle wasting, clubbing. This is all sign and symptoms of chronic liver disease. Again, here is what's called capitis medusa, is dilated veins around the abdomen, gynecomastia because difficult in handling of estrogen, jaundice, palmarothema, spider nevi is small dilated veins in the chest, ecchymosis from coagulopathy, clubbing, low albumin cause what's called leukoplakia, is white nail, and in advanced stage when your body is not coping and not handling the toxin, the ammonia patient will have what's called asterixis, flapping tremor, and fetor hepaticus. So is a wide manifestation, but this is all indicate late stage of disease.
Slide
not moving.
Not moving.
Sure. Is it moving now?
Yes.
Okay. This one, complications of liver cirrhosis.
No, we are still in clinical manifestations.
Now?
No. Still, Doctor, clinical manifestation.
I'm trying to. Sorry.
هي complication الآن الصورة الآن
واضحة. طيب اوكي. I would 1 second. Okay, so clinical complication of cirrhosis is either related to liver insufficiency, hepatic encephalopathy, coagulopathy, jaundice, or low albumin, or could be related to portal pressure. So high portal pressure can cause ascites, dilated veins around the esophagus, the varices, and can cause more symptoms like portopulmonary or hepatopulmonary syndrome. So how to evaluate patient with fibrosis? So we have this gentleman is 52 years old with diabetes on insulin. He came to our hospital, our clinic with fatigability and weight loss, and also leg swelling. And in clinical examination is just jaundice, so no other stigmata of chronic liver disease. So does he have liver fibrosis, and in which stage? So how to stage liver disease or fibrosis? So we have main three entity to go through it to define patient or to define the fibrosis. Liver biopsy, imaging modality, or looking for biomarkers. In liver fibrosis or liver biopsy, it is an invasive procedure and it is carry some risk, but it's helpful to identify the cause of liver disease as well as to tell us exactly about the etiology. There is a complications, mainly minor, related to site of an injection, and the high risk of majority of or major complication is very low. Contraindication, and usually we see it a lot in liver disease, those with coagulopathy, with low platelet, thrombocytopenia, those with a lot of ascites. So it's not all the time is applicable, although we can do different ways called transjugular through a jugular vein biopsy. So the disadvantage of such a modality is being invasive. There is a variety in observation, either inter or intra-observer, between 10 to 20%. Sample error is a bit low. Mortality is 1 to 2 in 10,000. The most common complication or side effect is the pain, which is in 20 to 30% of patients. There is a cost either direct to the processing of the sample or indirect to the way how we do the biopsy, from like hospital admission to beds to staff cost. Other modality is imaging. The most widely used modality is ultrasound. There is another modality called elastography, either transient elastography, Fibrascan, which is more widely available, or magnetic resonance, MRI elastography. Ultrasound is relatively low cost, accessible, lack of radiation, and can detect cirrhosis or advanced fibrosis complication like splenomegaly, portal hypertension, ascites, or liver cancer. But the sensitivity of such a procedure is low, is around 54%, with a bit specific, good specificity is 95%. It's not good for early fibrosis. So once you see some changes in ultrasound, that means in advanced stage. Second modality, it is a Fibrascan. Fibrascan, it is a modality we can use. It is a separate machine. We can use it to evaluate scar tissue. It's mainly depend on wave shock that go through the liver. And the idea that the liver is so viscous, so the flow or the wave will not transmit as faster as in a hard organ. So when you have fibrosis, the liver will get more harder, and the wave will go through or propagate more faster. In such cases, the fibrosis, we can get it, or the number we can get it, we look to the chart in front of you, which is different between the etiology. So Hep B, different than hepatitis C, than alcohol, than fatty liver. So when you have that number, will tell us exactly what stage of fibrosis. Fibrascan is good in determining early or minimal fibrosis or late stage of fibrosis, but there is, as you see, there is overlap in intermediate stage. You need training, and it's a bit costly, is around $70,000. So it's a costly procedure. So what's the disadvantage of Fibrascan is there is a failure rate is around 3%. It's dependent on body mass index. So anyone is obese, weight more, BMI more than 35, there is a probability that will not get a good reading. Unreliable in 15%, expensive, need more training. And again, as I said, like there is a lot of confounder in that. Patient with congestive heart failure, they can get more higher reading. Patient need to be fasting for around 6 hours, and so on. Biomarkers, we have two ways to detect fibrosis, either by direct biomarkers, and Dr. Tamimi will talk about that, and indirect biomarkers. Indirect biomarkers, what we use and widely available is AST, ALT, platelet count, INR, bilirubin, and albumin. And this is like in liver cirrhosis, you can see the ratio is more than AST, more than ALT, low platelet, high INR, high bilirubin, and low albumin. And this is widely available and expensive, but non-specific because other diseases can cause that. And once you see it, is indicate again late stage. Other biomarkers, what we do usually, we calculate what's called fibrosis score. This is a score developed based on studies, taking into account indirect biomarkers, patient profile, and usually is specific to etiology. So, for example, we have score for fatty liver, we have score for hepatitis B, we do have some score for viral hepatitis, Hep C. So is it useful to identify again the minimal fibrosis or advanced fibrosis, but again, intermediate stages is difficult and is limited to diseases. So why we are doing this to identify fibrosis and working hard on that, simply to identify early fibrosis, stop disease progression, and return patient back to the normal level if we could. Why? Because there is a clearly survival benefit. If you can see here, compensated cirrhosis, their median life survival is 12 years compared to someone is decompensated, which is roughly around 2 years. So what we usually do once we identify a patient is having fibrosis or in compensated stage of fibrosis, we screen them and try to prevent further progression to decompensated stage, death, or developing of cancer. So viral hepatitis, we give treatment. For fatty liver, we give them some instruction to do and controlling risk factor. Autoimmune, we give them immunosuppression, hemochromatosis, we ask them to do phlebotomy. And in patients with cholestatic liver disease, we give them ursodeoxycholic acid. So this is our aim to prevent further progression of cirrhosis. That will not happen before getting a good biomarker that tell us that patient is having fibrosis, and with more detail or more like data about fibrosis or biomarkers about fibrosis. So this is like last slide for me, and thank you for having me again, and sorry for the technical problem.
شكرا دكتور هادي, الله يعطيك العافية. Now we will move on to our next guest, Dr. Walid Al-Tamimi. Dr. Walid is well known and the same as Dr. Hadi, mashallah, very rich CV. Dr. Walid Al-Tamimi, Associate Professor, Consultant in Clinical Chemistry. He is also the head of Division of Clinical Chemistry in the Department of Pathology and Laboratory Medicine at King Fahd National Guard Hospital in Riyadh, Saudi Arabia. He graduated from Pre-Medical Program College of Medicine in 1983. In 1986, he granted his bachelor from King Saud University in the College of Science, Saudi Arabia. In 1987, he granted a certificate in Laboratory Medical Technology. Then he granted his PhD in biochemistry from University of Essex, England in 1993. In 1996, he continued his postdoctoral in the School of Medicine in Washington University in St. Louis, USA. He got his academic positions in 1989 as a laboratory medical technologist in King Fahd National Guard Hospital, then as a medical education coordinator in 1989 as well. In 1993, he was working as PhD student, then a clinical chemistry fellow in King Fahd National Guard in 1995. Then since 1995, he is working as a consultant biochemist. From 1997 to 2006, was working as a visiting professor in College of Medical Applied Science in King Saud University. Also a medical research coordinator in King Fahd National Guard from 1998 to 2001. Also, he worked as assistant professor in the Department of Basic Science in the College of Medicine at King Saud University for Health Science in King Abdulaziz Medical City. Very rich, mashallah, CV. He also worked as a deputy chairman of Biomedical Sciences in the College of Medicine at King Saud Abdulaziz University for Health Sciences National Guard. Also academic program director from 2009 to 2011 in the Department of Clinical Laboratory Sciences. Also program director for Medical Laboratory Technologies Training Program in the National Guard. And from since 2016, he is phlebotomy program manager in the Saudi Commission for Health Specialists. He is a member of many organizations around the world, American Association of Clinical Chemistry, Association of Clinical Biochemists, and others. He is also a CAB inspector, and mashallah, he has more than 70 paper published and more than 50 abstract and presentation in different conferences and workshops. Please join me. Welcome Dr. Walid Al-Tamimi. تفضل يا دكتور.
Assalamu alaikum wa rahmatullah. Thank you very much, Dr. Zahar, for this nice introduction. And I'd like to thank also the Saudi Society for Clinical Chemistry for inviting me to be speaker, and Snibe company for supporting me in this workshop. Bismillah ar-Rahman ar-Rahim. Have you seen my slide?
Yes, Doctor. Tfadal.
Okay. I'm going to talk about serum biomarker and liver fibrosis. Dr. Hadi has mentioned it in his first presentation. I just would like to disclose that Snibe company has supported me to present this webinar. And as Dr. Hadi has said, I will just skip many slides about the introduction about liver diseases, but it's enough to say that it represents the 5th most common cause of death, having liver diseases. Chronic hepatitis B in our region, chronic hepatitis C, and NASH and NAFLD are the most causes of liver diseases, which we have a global prevalence of cirrhosis from 4.5 to 9.5 based on from the population that having chronic hepatitis or B or C or other in that develop cirrhosis. Dr. Hadi has talked to you about what is the liver fibrosis, and he just mentioned that this is a scarring process that represents the liver response to injury. I will not go in detail here, as you have just said. This has also been shown by Dr. Hadi, this slide, showing the progress of chronic hepatitis into early fibrosis, and then cirrhosis and liver either having hepatocellular, which need treatment to go for liver transplant. If we see here, this is the part where we need to have an early marker for fibrosis to help us and help clinician and patient to identify if there is any early fibrosis, as the golden standard biopsy is doing now. But again, this has been shown by Dr. or explained by Dr. Hadi. The liver biopsies, it is about liver puncture and depth of 1.5 to 2 centimeter, 10% methanol to fix the sample, embed with the paraffin, slice, stain, and observed by microscope. It is the gold standard to identify fibrosis, and there is a grade system and stage system that help the pathologist to identify at which fibrosis stage and degree or that this patient has gone through. So we have a system that start from in the grading from G1 to G4, as explained by Dr. Hadi, and then we have stage from 0 to 4, represented by F0, F1, F2, and so on. So, but again, there is some limitation of liver biopsy that morbidity and mortality could happen at a low, very low scale. Sampling error, costly and time-consuming, required hospital visit and expert. The error rate is up to 25 to 35% of any higher stage above 1. Less experienced pathologists perform less well than expert and cannot perform repeated biopsy at short interval to assess liver disease or affect the therapeutic due to the hazard. So there is a need to have some serum biomarker. Again, when Dr. Hadi mentioned in his slide, there is a direct and indirect way of measuring those serum biomarker. He mentioned that the normal that we normally measure, the liver function test and clotting factor and bilirubin and cholesterol, but the direct that require fragment of liver matrix component produced by hepatic stellate cells during the fibrotic process, such as lemon and collagen 4 and collagen 6, amino terminal fragment of procollagen 3, and cholylglycine and hyaluronic acid. I'm going to talk about these, but I will show you also more details about hyaluronic acid, as we have done little study in our lab for correlation of two assays. The first matrix marker that is laminin, which is a major non-collagens glycoprotein synthesized by the hepatic stellate cells and deposited in the basement membrane of the liver. In chronic liver disease and fibrosis, it is progressively deposited in the liver cavities. Its serum levels or values have been related to the degree of portal hypertension and is correlated to the liver fibrosis degree and vein pressure. Increases in lemon concentration are positively correlated with the extent of fibrotic transition of the liver. Determination of laminin in serum improve the possibility of clinical chemical diagnosis of liver fibrosis and cirrhosis. In a study done in 1988, there was distribution of laminin concentration in population of healthy subject, individual with non-hepatic disease and patient with fibrotic liver disease, and we can see that in cirrhosis and fibrosis, the laminin concentration are higher in this study. If we go for the etiology distribution, the laminin concentration of patient with liver disease according to the etiology, we can see the cirrhosis in the first bar and fibrosis in the second bar in patient with ethanol toxic, and cirrhosis and fibrosis in post-hepatic, cirrhosis only in primary biliary, and cirrhosis and fibrosis in unspecified liver disease. We can see there was no significant differences between these according to this study. However, it was an old study. The second biomarker is type 4 collagen, which is the most abundant structural basement membrane component, and that serum collagen 4 levels are elevated in a variety of liver diseases. In particular, serum collagen levels have been found to be predictive of therapy response in hepatitis C infection, and to be sensitive indicator of therapy response in abstaining alcoholics. This type 4 collagen is content increased with progression of fibrosis, a useful marker for assessing the fibrotic stage in patient with chronic hepatitis C, and in alcoholic liver disease, type 4 collagen content in patient increased significantly with the progression of fibrosis staging, as we see here in this study. It's showing the grading or staging is higher for collagen type 4, has been sensitive, as has been identified as a sensitive indicator of the presence of cirrhosis in hematochromatosis. The third marker that we looking for as fibrosis, early fibrosis marker is procollagen type 3 amino terminal peptide, which is amino terminal peptide of type 3 procollagen, the cleavage product during the conversion of procollagen 3 into collagen 3. This is a major constituent of the connective tissue, and its relative concentration in a basement membrane is higher in hepatic fibrinogenesis and is closely followed by an increase in its serum level. In acute hepatitis level, level of serum procollagen type 3 correlate with aminotransferase levels like ALT and ST. In chronic liver disease, this biomarker reflects the stage of liver fibrosis. This study shows that serum level is a prognostic marker in patients with alcoholic liver diseases, and we can see that the serum concentration of P3MP in patients with alcoholic liver disease in relation to the degree of liver fibrosis. So in patients with having no fibrosis compared to those slightly fibrosis to moderate and severe, with having the cutoff of about 3.4, increasing above this level will indicate that could be part of fibrosis is happening. Also, in this diagram is showing that survival curve in group of patients with alcoholic liver disease according to elevated versus normal levels of serum P3MP. As we see in a normal, the survival rate is compared to those with high P3MP. The fourth biomarker is Cholylglycine, which is a combination of secondary bile acid with glycine conjugated bile acid, and is synthesized by the hepatocyte and discharged into the gallbladder along with the bile into duodenum to help the digestion of food. About 95% of bile acid reabsorbed in the distal ileum, and it excreted in the form of protein binding in serum. The total amount of overflow into systematic circulation is less than 1%. When liver cells are damaged, the capacity of Cholylglycine absorption reduces, increasing Cholylglycine concentration in the blood. Cholestasis increase Cholylglycine content, but also to the blood glycoglycine levels increase. The glycoglycine test system is a device intended to measure the bile acid glycoglycine in serum, and measurement obtained by this device are used in the diagnosis of treatment of liver disorders such as cirrhosis or obstruction liver disease. According to the FDA, it raises early in the liver disease, often several weeks before conventional liver function tests become abnormal, and thus the patient who is suspected of having liver diseases is a candidate for establishing the diagnosis of liver disease with serum Cholylglycine measurement. The hyaluronic acid is a polysaccharide with high molecular weight, glycosaminoglycan, and is particularly found in every tissue of the body. It is synthesized in synovial lining cells and hepatic stellate cells by hyaluronidase. This is the structure of hyaluronic acid, and its function is a structural role connective tissue matrix, participate in cell-to-cell interaction, and work as fluid retention and lubrication of joint. The possible causes of elevated hyaluronic acid is increasing production, which happen in inflammation such as rheumatoid arthritis, or increase release of hyaluronic acid from tissue such in cell damage. And there is a decrease of hyaluronic acid removal from the plasma, where there is decreased activity of liver cell due to fibrosis and cirrhosis. So hyaluronic acid shows a negative predictive value of about 98 to 100 for cirrhosis, and is of great value in excluding cirrhosis. In treated chronic hepatitis C patient, the response to treatment was reported to be associated with a reduction in serum hyaluronic acid level. So we are expecting a low level in those patients with fibrosis or cirrhosis. Hyaluronic acid measurement may be helpful in evaluating the extent of liver fibrosis, differentiating non-cirrhotic from cirrhotic liver, estimating the severity of fibrosis in alcoholic liver disease, and predicting liver fibrosis stage in patients with hepatitis C virus. So accuracy of hyaluronic acid for predicting liver fibrosis stage in patients with hepatitis C has been done in a study in 2005. In this study, they have shown the relation between the stage of fibrosis and hyaluronic acid level at different level of stage of with concentration of hyaluronic acid. The serum hyaluronic acid was significantly different among the stages of fibrosis and had a significant positive correlation with the degree of fibrosis. Here also we see the sensitivity study in this study showing that F2 to F4 area under K was 0.7, and in a stage of identifying the by hyaluronic acid severe fibrosis or cirrhosis in stage F4. So they conclude in this study that in severe fibrosis, area under K was about 0.9, and the cutoff value was 46.1. The sensitivity was 85, specificity was 80%, and positive predictive value and negative predictive value was 51 and 96 respectively. In cirrhosis, the area under K was higher, 0.92 at same cutoff. There is no information has been given in this study about the sensitivity and specificity of this test. In their conclusion, they found that the serum hyaluronic acid was significantly different among the stage of fibrosis and had a significant positive correlation with degree of fibrosis. And at area under care, there were any level of fibrosis 0.67, moderate fibrosis was higher 0.87, and severe fibrosis 0.89, and cirrhosis was 0.92. All of which were area under K significantly higher than 0.5. I will just show if we combined those 5 markers that we have just presented in this presentation we can see that the sensitivity and specificity are improving. If we just say, show here individually in different study that the sensitivity varies between 37 to 82 and specificity also on the same range. But if and the right diagnosis index that can be calculated by sensitivity plus specificity minus 1, giving this value. If we combine them, improving the sensitivity, as we see in this rectangle, if we combine hyaluronic acid with P3NP, we found that about 55 improve and the specificity 87.7. Hyaluronic acid with another marker, collagen 4, we found that the sensitivity is about 43 and the specificity is 100, and so on. We see some improvement only in the some biomarker. There is no much improvement in the if we combine 3 or 4. However, the specificity is remaining stable and improving, but sensitivity is still not meeting our expectation. So just briefly in a few slides, I will show you the immunoassay method for determination of hyaluronic acid in blood patient with liver disease that we have done in our lab. There was an aim to do the study that various methods are discordant and HL and hyaluronic acid are not standardized, and therefore we study to compare and clinically validate this method to each other to find which is the best and with the clinical and manifestation correlation. Although it's a very low scale study, but we collect 42 samples from liver adult patient, and additional 11 samples were collected for as a control. Patient has been all assessed and diagnosed with clinically or bioradiologically, as well as by liver biopsy and Fibrascan. The patient has been divided into 3 groups. One group with chronic hepatitis with liver cirrhosis, group 2 chronic hepatitis with cirrhosis, and 3 patients with liver cancer, and the control arm in the 4 group. There was 2 methods. We compared the chemiluminescent immunoassay method from Maglumi Snibe with reference range less than 100, and compare method with Fujifilm Waco chemicals from Germany based on lactic agglutination trophometric method, and has been applied to general clinical chemistry analyzer Architect as an open system. We also measured alpha-fetoprotein by chemiluminescence microparticle immunoassay on the Architect Abbott. Result, there were about 93% total agreement with correlation, about 0.997 between the 2 assay based on its assay cutoff, showing a very excellent correlation between the 2 assay, the Waco using Abbott channel and Snibe immunoassay with a regression of 0.997. The clinical sensitivity and specificity of hyaluronic acid was showing that about 41% sensitivity in group 1 and specificity of 100%, and negative predictive and positive predictive value of 152 respectively, with accuracy of 64. Hepatitis with cirrhosis showing about 75% sensitivity with 100 specificity and predictive positive value of 100 and negative predictive value of 73 with a higher accuracy 85. With those with liver cancer, hepatocellular cancer, sensitivity was surprisingly also higher, and specificity and with a good positive predictive value and negative predictive value and higher accuracy, taking into our future consideration to think about hyaluronic acid as additional marker or exploring its usefulness, clinical usefulness in hepatocellular carcinoma. So overall sensitivity and specificity at different cutoff value has increased. If we increase the cutoff value, specificity remain stable and higher. It's decreasing sensitivity over increasing the cutoff value, but increasing specificity. So using higher cutoff doesn't really improve the sensitivity in our study. The characteristic of the two assays used in this study showing the specification and Fisher showing this table. So conclusion of our study, the two hyaluronic method using Architect open system using reagent from WACO, and on the other hand, the Maglumi immunoassay are comparable and agreed with each other in evaluating patients with cirrhosis and hepatocellular carcinoma. The best clinical utility of this test is to rule out the liver disease rather than to rule in. And the overall conclusion of this presentation is serum biomarker can aid in diagnosis and prognosis in liver fibrosis and cirrhosis. Hyaluronic acid is elevated in liver disease associated with fibrosis, but vary in liver diseases of different etiology. Additionally, hyaluronic acid level increase continuously with the severity of liver fibrosis. Therefore, it may be help in diagnostic of liver disease, evaluation severity of liver diseases, replace the performance of liver biopsies, indicator of liver fibrosis. Also, this test is very easy to use, simple, quick, and non-invasive test. In Snibe or Maglumi, they have, just for your information, they have all these 5 tests that I have mentioned. However, there are so many other biomarker that not been mentioned in this presentation, but at least to start with these tests for diagnostic approach, combining with other clinical assessment to detect and quantify hepatic fibrosis is really very helpful in our laboratory and with the clinician. These are my references, and thank you for your attending and for your attention.
Thanks, Dr. Walid Tamimi, for this great presentation. I will now open the board for questions. First, I will answer a question from many attendees regarding the SMEs and how to register. After this workshop, a link will be sent to your emails having a survey, and you will register your Saudi Council registration number, and it will be recorded in your account with 2 CMEs. Another question is, are these markers available now in our laboratories?
The answer to this question, yes, it is available and we can use it. We are using now the hyaluronic acid, and we are aiming to use the other marker.
Sure. Another question, Dr. Yes, go ahead, Dr. Walid.
It is useful to first to establish like a communication with the clinician to decide on which marker, because you don't want to report something that they also are not familiar with or may not able to have an interpretation. Sometimes you offer it and wait for them to suggest which one that can be used to combine alpha-fetoprotein, for example, or the in case of hepatocellular carcinoma, or in case of fibrosis, liver biopsy.
Okay, thanks, Doctor. Another question, Dr. Hadi, is about non-alcoholic steatohepatitis for fatty liver disease. Which biomarker most important? Dr. Hadi? Dr. Hadi, can you hear me? I think maybe Dr. Hadi has a problem in the communication. Dr. Walid, can you answer this question?
If you mean the which one is better to for the among those 5 markers, for example, or
which biomarker?
Can you repeat the questions, Dr. Hadi? Dr. Zahid?
He's talking about non-alcoholic steatohepatitis, non-fatty liver disease.
Yeah, I got the best for NAFLD or non-alcoholic liver fatty disease is the ultrasound. ALT also to some extent is also can combine, but the gold standard is ultrasound to detect if there is any fatty liver on the liver. However, it's a very good question because also open an eyes, as we mentioned in the beginning, that NAFLD and NASH are all with obesity, of course, can be progressed through fibrosis process to cirrhosis. This pathophysiological process may have some windows for those markers to be evaluated and helpful in the evaluation of those patients. It could be promising. To the extent of my knowledge, I have not seen any study done for NAFLD using these yet biomarkers.
Okay, there's a question about certificate of attendance. Actually, unfortunately, we are not providing these certificates. If there is no more questions, I think, yeah, what is the difference between AST and ALT? Dr. Walid?
Sorry? AST and ALT?
Yes.
Okay, these are enzymes all produced in the or liver cells. The ALT in the cytosol and both in cytosol, but AST also contribute from mitochondria and cytosol. In case of liver cell damage, it will appear in the serum. It helps to tell us if there is any inflammation of the liver has been occurred.
Okay, with this we yes, doctor.
If this answer is meeting the questions.
Yes, yes, yes. Okay. Is there anything, Dr. Hadi, you want to add? Okay, with this we conclude. Thanks to our speakers, Dr. Walid and Dr. Hadi, for this great presentations. We appreciate your time. We wish you all the best, and thank you to our attendees for their attendance. And we will see you, inshallah, in next event soon, inshallah. Thank you so much.
Thank you for attending, and thank you for having me, and hope you a good evening. Assalamu alaikum.
Assalamu alaikum. Thank you all. Assalamu alaikum.